he recently retired from the private practice of psychiatry, but he still practices part-time in Queen Emma Clinic, a hospital-based primary care clinic, including caring for mostly Medicaid patients and teaching psychiatric issues in general medical care to internal medicine residents. He is an assistant clinical professor of both medicine and psychiatry at the John A. Burns School of Medicine in Honolulu. He's also a past president of both the Hawaii Psychiatric Medical Association and the Hawaii Medical Association. Dr. Kemble has a long-standing interest in health policy and healthcare reform, and he was appointed to the Hawaii Health Authority in 2011, charged with overall health planning for the state of Hawaii and with designing a universal healthcare system covering everyone in the state. He has been a member of Physicians for National Health Program, a physician single-payer advocacy organization since 1989, and he currently serves on the PNHP board. And in his capacity on the One Payer States organization, he is actually the chair of the policy work group. So thank you so much, Steve, for joining us today. And I'm going to be popping off because I have to get ready for this caucus tonight and also possibly a resolution at the League of Women Voters Convention. So I'm asking Liat to be sure to record this. Are you doing so? Great, thank you so much. And thank you, Dr. Kemble.
Thank you. Okay, let me see if I can share screen here. It says you have to authorize it, Lee. Host, it says host disabled attendee screen sharing.
Try now. I think it should work.
Okay, let's try. Okay, great. Can you all see that? A title slide. Everybody can see that? Okay.
Yes, Dr. Kemble.
All right. What I would like to do as I go through this is encourage people to ask questions as we go along. Let me see if I can open the chat function. Wait, hold on a sec. Yeah. I'm not seeing, when I do screen sharing, I don't see the chat box. So I guess wave your hand or unmute yourself and ask a question, and we'll do it that way.
Sounds good.
Okay. Nothing to disclose. Okay, the original structure of Medicaid as passed in 1965, it's funded with federal and state matching, roughly 50-50 in wealthier states, but an increased federal share in poorer states, which effectively transfers funds from richer to poorer states to enable them to have a viable Medicaid program. But although it's funded jointly, it's managed by the states, and there's considerable variability in optional features and payment rates. And optional features, there are some mandated benefits and some optional benefits, and some states do offer the optional ones and some don't. And they are able to set their own payment rates. So those vary considerably from somewhere around Medicare rates to like less than a third of Medicare rates in some states. There are three categories of Medicaid: aid for dependent children, which is for poor children and their parents, which is often combined with State Children's Health Insurance Program, or SCHIP. General assistance, which is for working age adults who are disabled, and aged blind disabled, which is those who have qualified for Social Security Disability, or SSI, or who are older and qualify for regular Social Security. And after 2 years, those who are in Social Security and have put some money into the system over the course of their working life, they become eligible for Medicare as well as Medicaid, and then they're called dual eligibles because they have a combination of both insurances. Okay, the Medicaid program has what's called categorical eligibility, as opposed to social insurance like Medicare, where everybody over 65 automatically gets it. You have to be you have to meet criteria, which is there's means testing. You need to be below a certain income level. And for some benefits, you need to have no accumulated assets beyond a couple $1,000s. And the level at which benefits kick in varies from state to state. For many years, Hawaii used 200% of federal poverty level, whereas other states used only 100%. And there's a statutory maximum of 300%. If a state were to implement 300%, it would cover a large number of working poor as well as the unemployed and disabled in the program, but nobody's ever gone above 200%. Medicaid covers long-term care, and it has a what they call Medicaid estate recovery, which means you have to exhaust your assets before you become eligible for Medicaid for long-term care. So you have to, if you own a house, you have to sell the house, you have to spend down the money, and only when you're actually impoverished do you get Medicaid. This means that it really has a devastating effect on elderly people who would hope to leave something to their children, because if they need long-term care, they can't. It gets taken away. The Medicaid estate recovery feature of Medicaid was added in 1993. It's required for long-term care and it's optional for other categories. What that means is if you are not in long-term care, you're in regular Medicaid, and you know, you're impoverished, but you have a house. With the Medicaid expansion, they can't take your house away, but they can sign you up for the Medicaid program. When you die, they can add up everything that Medicaid spent on you and take it back from your estate, so they can go after your house and take it away from your children. And for things other than long-term care, this is optional. Some states have implemented it, some have not. And there are definitely cases of older people who have refused to accept Medicaid because they didn't want to have the state take away their house, and they wanted to leave it for their children. So they went without care rather than do that. Medicaid has become the primary source of funding for long-term care for all but the wealthy. And it's a huge program, the long-term care part of it. Of course, because eligibility depends on income, the number of eligibles varies inversely with the economy. In an economic downturn, a lot more people go on Medicaid. And when the economy is doing well, the numbers decline. So the burden on the government varies inversely with the economy. The benefits in Medicaid are generally comprehensive, and it was originally designed with no copays or deductibles, no patient cost sharing. And it also includes some other social support, such as transportation services, translators, and things like that. And there are optional benefits that vary by state, such as the general assistance category for childless working age adults with some kind of disability. Some states implemented that, some did not. Some states offer dental care for adults, others do not. It is required for children. Some states offer basic auto insurance as a Medicaid benefit, so that if you own a car, you're not forced to give it up if you go on Medicaid, and that way you have an easier pathway back to work. And then there are very variable formulary restrictions in the Medicaid program. Some states, the formulary is fairly broad, others it's very restricted. The original program paid doctors and hospitals a fee for service, which have generally been lower than Medicare, but vary a lot by state. And this has a big effect in private practice physician participation. Okay, the Medicaid expansion under the Affordable Care Act eliminated the asset test for working age adults. In other words, you no longer had to have no assets, you just had to have low income. So this meant that you could own a house, but if your income dropped because you lost your job, you could qualify for Medicaid and they wouldn't take your house away immediately, although they can when you die. And the Affordable Care Act said the expansion applied to anyone up to 133% of the federal poverty level for income. And pretty much all the states fell in line with this. Hawaii, that used to have 200%, dropped their eligibility to 133% to match the federal requirement. They could have kept it higher, but they didn't. They just went to the standard federal 133% level. And most other states did the same thing. So as I said, your assets and other resources don't count, only your income, and it's your modified adjusted gross income, which is a formula that's a little different from the one for your adjusted gross income on your taxes. The expansion was initially 100% federally funded, and that dropped to 90% over several years. And the asset tests still apply for non-expansion Medicaid populations. In other words, pregnant women, parents of children, blind, disabled, seniors, they still all have asset tests. It's only the expansion population that doesn't. And it did not expand Medicaid to illegal immigrants, although legal immigrants who are not US citizens may still be eligible. And states still vary in asset test requirements and Medicaid estate recovery for benefits other than long-term care. Okay, Republicans have been trying to change Medicaid by imposing cost sharing, imposing work requirements, increasing documentation requirements for proof of citizenship and legal immigration status, all of which result in a lot of people being bumped off the Medicaid rolls. And patient cost sharing and work requirements have been approved since Trump came to office, but they have generally been shot down by the courts or have been shown to have disastrous effects on enrollment. And they are contrary to the intent of the original Medicaid law as specified in statute. And so they have generally been shot down. There's also a push by Republicans for block grant funding of Medicaid, which would almost, in other words, a federal contribution is a fixed amount and doesn't vary with how many people are eligible. And that would inevitably result in marked reductions in funding over time. And those proposals have been blocked by Democrats so far. All right, the big issue with Medicaid to me is Medicaid managed care. And starting in the mid-90s, many state governments started contracting Medicaid out to managed care organizations. Two of the handouts, the Goldsmith et al., Medicaid managed care, lots of unanswered question handouts go over this in some depth of what the problems are. But there's a thing called a Section 1115 waiver, which states submits to Centers for Medicare and Medicaid Services requesting a change in the original Medicaid structure. And most of those have been to allow them to use managed care organizations. Most states started by doing this with aid for dependent children and general assistance, and a few states added aged, blind, disabled later, including Hawaii, although many states still pay for aged, blind, disabled with fee-for-service and only use managed care for the first two categories. By 2017, over 2/3 of all Medicaid recipients were under managed care contracts. And the reason that states did this is because they were tired of allocating a budget for Medicaid, having to pay the claims as they came in, and discovering 10 or 11 months into the year that they'd run out of money from what they budgeted, but they were still on the hook for whatever the cost of care was. And so they hated the unpredictability of the budget. So what they wanted to do is give a managed care company a set amount of money for the year, and the managed care company would take the risk of covering the cost of care and guarantee that they would cover everyone's care within that budget. So that gave the state budgetary predictability. They hoped that the managed care companies would be able to reduce unnecessary care, make care more efficient, and save money and improve care coordination and quality, and that they would have more flexibility to offer extra benefits and manage their networks and use innovative payment schemes, et cetera, et cetera. So that was what they intended. But the main thing that they got right away was the budgetary predictability. So 40 states contract at least aid for dependent children and general assistance to managed care organizations. 11 states, including Vermont, retain Medicaid as a fee-for-service program with the state bearing risk. And some states have implemented primary care case management or enhanced primary care case management instead of managed care organizations. What this is that primary care doctors are given an extra, like a capitation rate, a partial payment, but they get an extra per member per month payment to cover care coordination that is outside the fee-for-service system. And it may also include community-based programs such as teams that will help manage complex patients who are in and out of the emergency room in the community and keep them out of the emergency room, coordinate with primary care, and become a community extension of the primary care practices. That's enhanced primary care case management. Now, the state of Oklahoma tried to implement managed care in the 90s like everybody else, but they had trouble coming up with plans outside of their major urban areas. So Oklahoma City and Tulsa ended up with 2 or 3 managed care organizations, and the smaller towns and rural parts of Oklahoma went to enhanced primary care case management instead of managed care organizations. So they had a natural experiment comparing the two. And after several years, they discovered that the primary care doctors were doing quite a bit better at managing care and keeping it cost effective than the managed care organizations. So they fired the MCOs and expanded enhanced primary care case management to the whole state. North Carolina was also a pioneer in enhanced primary care case management, and they're sort of have been the model program, although their current Republican administration is in the process of dismantling that system and replacing it with managed care organizations, mainly because their legislature has been lobbied by the managed care organizations. Okay, Oregon is another interesting case. They have a system of coordinated care organizations. And the original idea, there's also an article on this that's in your handouts. The original idea is that Oregon's governor wanted to have one CCO for each region so that it would not be a competitive program, but one area would have a group of doctors and hospitals who would be paid a set budget to manage the care for their population, but not in competition with anyone else. And it turned out that they ended up having to have competing managed care organizations in the large urban areas such as Portland, but most of Oregon still has one per region. And they are given a capitated budget, or a set budget for their region, and they're free to use the money in flexible ways. So they might decide to buy, if somebody is coming into the emergency room a lot with asthma because they are poor and have an overheated apartment, they can buy an air conditioner and keep them out of the hospital if that will reduce their medical spending. So they've been able to use somewhat creative and flexible measures to improve health beyond what's usually considered to be reimbursable health care. And that, Oregon's governor got a deal with the Centers for Medicaid and Medicaid Services to have $1.9 billion in startup money to do this in exchange for limiting the rise in Medicaid spending to no more than 3.9% per year. And they actually pulled it off and made a lot of money in their first few years. And it was highly successful. Although more recently, there have been problems in the rest of Oregon's insurance market, and there have been funding cutbacks, and it's unclear how this is all going to work out in the long run. But it was an interesting idea. Those are the main innovations. Okay, so what does managed care do to insurance risk? This means, okay, who's on the hook if somebody develops leukemia and needs a bone marrow transplant, or if you have a baby born 2 months premature with multiple defects and it's going to need custodial care for the rest of their life, or things like that. Who's going to take the risk for expensive complications? In the original Medicaid program, it was the state. So that if a lot of bills came in because of a complex case like that, the state would have to come up with the money to pay for it. And if they didn't have money in this year's budget, they would have to increase the budget next year to cover that shortfall, and then guess what it would be for the next year. But the state has the risk. With managed care, the managed care organization has the risk. They're on the hook, and they generally make sure they're well enough paid so they're not actually going to lose money. There are very few that have ever lost money, and if they do one year, they make sure to jack up the premiums the next year so that they don't continue to lose money. So basically, the state is paying a premium to the managed care organizations to make sure that their risk doesn't hurt them. What happens to accountability? When you contract Medicaid to managed care organizations, if there's any problems with access to care, or let's say the managed care company says, well, we have 3/4 of the doctors in our community participating with our plan, but if patients start calling doctors and say, I have Medicaid, will you see me? They can't find any doctors who will see them. And this kind of thing has been rampant with Medicaid. If you want to complain about that, you have to complain to the managed care company, and they basically can blow you off, and the state doesn't even know about it. So the accountability for the successes or failure of the program is shifted to the managed care organization, and the state says, well, we're not doing that. We contracted it out. You have to talk to the plan. What does it do to cost? All the plans claimed they were going to save money to the state, and they all claim, and after they were implemented, that they had saved money for the state. But there's, other than Oklahoma, there is no control group. So they would say, well, you would have spent X amount of dollars, and they come up with their own projections and make sure that it's more than what the state is actually spending and claim that they're saving money. And this has happened in every state with managed care. And in fact, in Hawaii, which was one of the early adopters, when we went to managed care, our Medicaid costs, which used to be tracking exactly the national average, started rising 3% faster than the national average ever since managed care was implemented in the mid-90s. So it doesn't appear that it's actually saved any money. And then access and quality of care for beneficiaries. Again, there's a huge problem with ghost networks and obstructions to care because of prior authorizations, and all accountability by the state has been farmed out to the managed care company, so you can't get any resolution of those problems. Medicaid managed care is very profitable.
I had a quick question about MCOs.
Yeah, sure.
Are they from like big insurance companies, or are they like more low? Like who are these MCOs?
It's a mix. Some are local from within the state, and some are the giant national plans like United Healthcare and WellCare and things like that. In Hawaii, we started out with 4 or 5 local plans, all of which were local, when it was only AFDC and GA. And then when they expanded it to aged, blind, disabled, they went with United Healthcare and WellCare, which are both for-profit national plans. And it's all over the place in the rest of the country. There are some local and some that are big insurance companies. So there is substantially greater profit in the programs that deal with sicker people, like the dual eligibles with both Medicare and Medicaid. And aged, blind, disabled is quite a bit sicker than aid for dependent children and general assistance. And you can see that profitability of the managed care plans really goes up as the severity of illness goes up. So they're making sure they're paid enough from their capitation rate so they're not going to lose, and that they have something to take home to their parent company also and their investors. As I said, there have been many studies showing that generally about half of the doctors listed in a plan directory are not actually available for appointments, in some cases higher than that. And all of the managed care contracts require them to have adequate physician networks, but the state has no ability to enforce that. They have very cloudy accounting. I believe it's United Healthcare mixes their Medicaid managed care financial data with commercial plans and Medicare Advantage plans, so you don't know what's what. The Obama administration negotiated with the insurance companies to call the medical loss ratio as the ratio of how much of your premium you spend on healthcare as opposed to administration. That's what it means. And anything spent on healthcare is considered medical loss. So the Obama administration allowed them to call quality improvement activities and medical management as healthcare, not administration. And so in 2011, every single insurance plan in the country switched medical management and quality improvement from the administration column to the healthcare column. Now they can spend as much money as they want, micromanaging care, denying care, obstructing care, and they get to call it healthcare, not administration. And so you don't know how much is actually being spent on healthcare anymore, because there's no limit to what they can spend on obstructing care, and they get to count it as healthcare. So they all report a medical loss ratio, and
Question about that.
yes.
And then I think you'll probably get to this, but I think 85% medical loss ratio was what was legislated. Is that right?
For the Affordable Care Act exchange plans and in the individual market, it's 85% for larger insurance plans and 80% for smaller plans. Yes, but like I said, the medical loss ratio, the formula to calculate it was changed so that now you don't know what it really is, but that's correct.
Right. So yeah, that's kind of what I was getting at. Do you have any idea of a ballpark what the true figure would be if you moved those columns to their appropriate place?
Well, as a matter of fact, I was on the board of directors of a local Hawaii health insurance company at the time that this happened. And this particular company was run by physicians, and they were particularly judicious in how much medical management they did. They tried to only manage things that really warranted management. And like if they prior authorized something and was almost always approved, they drop it from the prior authorization list, and they tried to be physician friendly. And they were spending 1 to 1.5% of their premium dollar on medical management. Compared to dealing with that company, dealing with any other insurance company in Hawaii involved a lot more obstructions to care. So my guess it's anywhere from 3 to 10% of the premium dollar maybe in the medical management category. And David Himmelstein and Steffi Woolhandler did do a study where they calculated medical loss ratios using the old formula of, not the current formula, using the old formula, and found out there's really been no reduction in actual medical loss ratio since the Affordable Care Act. So in any case, it becomes very difficult for states to obtain information to effectively regulate their plans and hold them accountable, so that the MCOs become a financial black box for the state. Yes, it's predictable, but you have no idea how the money is actually being spent or whether you're getting the appropriate bang for your buck. There's a 5-fold variation in plan reported administrative overhead. Again, as you said, the Affordable Care Act says you're not supposed to go above 15% administrative overhead, but some of them do. And the medical loss ratios went anywhere from 77 reported medical loss ratios on 77.9 to 114.4%, but that 114.4 was an outlier. All the rest were 77.9 to 95.5. Any plan that had 114.4% medical loss ratio would go under if they didn't recoup it with increased premiums the following year. So I'm sure that wasn't sustained. But in any case, you can see that some plans were getting a medical loss ratio below 80 to 85% in the Medicaid program, even though that was a requirement for commercial insurance. There are huge variations in insurance reserves, which is the percentage of your annual budget that's supposed to be set aside just in case you get high cost cases. And the question is this variability, is there some legitimate reason for it, or is it that some plans are taking advantage of the states? The state hoped to save on their own administrative costs by contracting Medicaid out to managed care companies, but states still have to have some administration to deal with the managed care companies. And if they only contracted aid for dependent children and general assistance out and are still paying for aged, blind, disabled fee for service, they have to manage that. So the end result was that the average state Medicaid administrative costs dropped from 5.8% without managed care to 4.9% with them. But there's wide variability, and some states are having to spend 10.8% of their Medicaid budget on administration, even with managed care. So Medicaid is generally around 15 to 20% of total state general funds, and how much of that is actually being wasted? This is the experience in Hawaii. We converted fee-for-service Medicaid to managed care for AFDC and GA in '94 and for aged, blind, disabled in 2009. And managed care resulted in increasing administrative hassles and costs for doctors and hospitals, declining physician participation, and worsening access problems. And as I said, our annual per capita costs rose to 3% faster than the US average from 2000 through 2014, which is the most recent data that Kaiser Health Facts reports. And that's been sustained for that whole period of time. Now, when they converted aged, blind, disabled to managed care in 2009, that includes most of the seriously mentally ill. And at the time that they did that, 2/3 of Hawaii psychiatrists signed up on behalf of their existing patients. But 4 years later, you couldn't find a psychiatrist accepting new Medicaid patients. So that's a drastic drop in access to care. And our mental health, ER, and hospital costs shot up 30% during those 4 years. You would think somebody in the state Medicaid program would have said, maybe we made a mistake, but nobody did. Nobody is willing to try to hold the plans accountable for this. This is a Connecticut experience. They had managed care for 12 years up to 2012, and their costs were rising at 45%, rose 45% between 2008 and 2012 over a 4-year period. They eliminated managed care organization, took back insurance risk, and self-insured Medicaid, and they offered enhanced funding and support for primary care and some care coordination services in the community. And the result was increased physician acceptance of Medicaid, declining ER usage in hospital admissions and readmissions, and their per member per month Medicaid costs dropped 14% between 2012 and 2018. That's $706 per member per month to $610 per member per month. And they are the only state I know of who has ever seen a drop in Medicaid costs. Every other state, every year, it always goes up. Their administrative costs are now 3.5% compared to 12.5% for Connecticut commercial plans. In your handouts here, yes?
Sorry, I had a question. How optional is Medicaid for physicians?
Completely. And there's two things. One, you can decide, if you're an independent physician, you can decide whether you're going to sign a contract with Medicaid or not, whether it's fee-for-service or managed care. Either way, you can decide whether you're going to participate or not. You can participate in one plan, all plans, or no plans. And even if you decide to participate, that doesn't mean you're going to accept new patients. Because what many doctors do is they sign up on behalf of their existing patients and then won't take any new ones. So there's a huge discrepancy between what the plans report based on the number of doctors that have signed a contract with them and what's actually available to patients. And the other thing is that they don't review their lists regularly. So many of the Medicaid managed care company provider lists include many doctors who have died, moved out of state, resigned from the plan, but the plan never keeps track of that, so they just keep reporting a larger list. They also do things like they will buy out some other plan and then adopt their provider list, even though the doctors didn't sign a contract with a new plan and have actually dropped out. So there's a huge problem with ghost networks. The Taubman article in your handouts is sort of a narrative report of what happened in Connecticut and how they went through the whole process and how they got it through. It's very interesting reading. Okay, the current push is for so-called value-based payment, which means the theory is that there's a lot of unnecessary care due to fee-for-service, because with fee-for-service, the more services you provide, the more money you make. So the assumption is that this is driving unnecessary care. We need to change the incentives by pushing insurance risk onto doctors and hospitals so that they're paid up front a set amount of money to cover care. And the more care they deliver, the more money they lose. And now they have a medical loss ratio, just like the insurance companies. It's turning doctors and hospitals into insurance companies. That's what it is. So they're the ones that are now having, quote, medical losses by delivering care, and they have an incentive to restrict care, and hopefully to restrict care only to what's really necessary. So this is the current health policy fad all over the country. It's being pushed big time by Centers for Medicare and Medicaid Services, and a lot of the Medicaid managed care plans are trying to jump on the bandwagon. The reality is, I don't know of any evidence that there was excessive volume of care in primary care anywhere in the country. I do think there's been some unnecessary procedural services that have been supplied, but you can't capitate specialists, because if you did, you would create a huge incentive for them to only deal with the healthiest patients, the lowest risk surgical cases, and to avoid anyone who's too sick. So nobody has successfully capitated specialists. You can capitate primary care because everyone is supposed to have a primary care doctor, and you can distribute it over the population more easily. But there's never been evidence of excessive care due to fee-for-service in primary care, ever, anywhere, certainly not in Hawaii. So anyway, the idea is, let's organize doctors and hospitals into HMOs, health maintenance organizations, or accountable care organizations. And the difference between those is an HMO has defined subscribers, so that you're either in the HMO or you're not. Whereas accountable care organizations, nobody signs up for them. Patients are attributed to a primary care practice or an accountable care organization based on where they are seeking care the most often. So it's a little more obscure mechanism for figuring out who's going to get the capitation rate. And there are actually a lot of problems with that, because many patients see more than one doctor in the course of a year, and you don't know who to pay the capitation rate to. But the idea is you organize them into an organization that can accept insurance risk and eventually be paid with capitation, so that they have the insurance risk. What this does is it creates an incentive. If you have been paid up front with capitation, you have an incentive to skimp on necessary as well as unnecessary care, and to avoid sicker, more complex and socially disadvantaged patients who might cost more, that which is called cherry picking. So these are inherent in the whole idea of pushing insurance risk onto providers. The architects of value-based payment recognize this. So they said, well, we'll deal with some counter incentives, which is pay for outcomes or pay for performance or pay for quality, so that we will measure whether you're doing appropriate things and make sure you get an incentive for doing all the right things so that you don't skimp on care. And risk adjustment, so we'll calculate how sick your patient population is and pay you more for taking sicker patients so you don't have an incentive to avoid sick people. The problem with this is that it requires very detailed documentation and data reporting. And the administrative costs are high. And the formulas for measuring performance or outcomes and for risk adjustment are extremely inadequate. So if you're paying for performance, what you do is you find a few things that you can measure, and then you give doctors a bonus for meeting those measures. But those things might be 2% of all the care a doctor is providing. So you're measuring them based on a very small percentage of what they do, and everything else is unmeasured because it's too complicated and you can't get at it. It's not easy to measure. Same with risk adjustment. The best risk adjustment formula that's in widespread use by Medicare and Medicaid only captures about 12% of the variation in spending per patient. And to try to go higher than that, you need even more detailed documentation and data reporting. And you need to be able to figure out what variables are outside the control of the doctor and hospital, and find a way to measure them and find a way to allocate how much they're costing in order to get a better risk adjustment formula. And the administrative cost of doing that becomes prohibitive. So you can never get better than 12%. So if you're only going to cover 2% of quality and 12% of risk, then the incentives to game documentation, avoid sick people, skimp on care, remain in place. You haven't solved the problem at all. So what we're seeing is markedly increased utilization management by health plans in recent years. Prior authorizations for drugs have been shooting up, and they've also started prior authorizing imaging and labs. And these are worse for the Medicaid managed care organizations. We're required to do much more detailed documentation, which is required for pay for performance and risk adjustment. And you get penalized if you don't report it. In Hawaii, the results, when Medicare did this, they started requiring much more detailed documentation and data reporting. Many independent practices said, well, I'd have to hire more staff and get a new computer system and it would cost me $50,000 and I'm just not gonna do it. So they quit taking Medicaid and Medicare. And that's been the actual result. Doctors now spend twice as much clinic time on the computer as paying attention to patients, plus charting time at home. And this is having very detrimental effects on physician morale and also on the cost effectiveness of practice. Also, Centers for Medicare and Medicaid Services has not been saving any money from the move toward risk-based contracting and value-based payment. Medicare accountable care organizations are costing more to administer than they can save from encouraging lower utilization. And many of the initial accountable care organizations have dropped out because they didn't want to lose money. And there have been no net savings from the program. If anything, it's increased costs a little. Another recent study looked at why do we spend twice as much as other countries on healthcare? Is it really because we have too much care due to fee-for-service? And what they found is that utilization rates in the US were largely similar to those in other nations, maybe a little on the low side. All those other countries generally use fee-for-service and they're spending half what we are. And it's prices and administrative costs that are driving the difference, not overutilization due to fee-for-service. So the whole rationale for value-based payment is based on a false proposition. These are, I'm just going to read them through because they're really fundamental. Restricting care, and they're obvious if you think about it, restricting care does not control cost. It does not restrict the burden of disease in the community. It just cripples our ability to manage disease in the most cost-effective settings. And it results in increased use of emergency rooms, hospitals, and prisons for care. And competition and financing of healthcare does not control costs or improve quality. It worsens disparities in access to care. And the reason for this is also fundamental. Too much of the risk in healthcare finance is already known in advance due to pre-existing conditions and social determinants of health. There's a lot of people where you can predict they're going to have either high or low healthcare costs. So that when you have competing organizations that are bearing insurance risk, the main driver of competition is not giving you better benefits, lower costs, better care. It's avoiding sick people and pushing them onto the competition. That's the primary driver of competition. If you start a new insurance company, health insurance company, and you manage to capture a healthier than average risk pool, you will make money. If you get stuck with sicker patients than the competition, you will be driven out of business. So this is the underlying primary driver of competition, is risk avoidance. What has been shown to work? Manage insurance risk with a single universal risk pool instead of using competition, fragmentation, and shifting risk onto providers. Assure universal access to care in the most cost-effective settings, not narrow networks and micromanagement of care. Keep administrative costs low and control prices, not utilization. And you can control prices if you do keep administrative costs low, because that's what's driving the high prices. So if you can reduce administrative overhead, you can reduce prices without hurting the providers of care. Rely on and promote physician professionalism and intrinsic motivation to serve their patients, not financial carrots and sticks. And care coordination should be the front lines of care by the people who know the patient's individual situations, not distant managers working for insurance companies following metrics. The main barriers to care coordination are the fragmentation of care by competing plans and the restrictions they impose. So from here, that's where we are now. I would like to move into how could we design a truly cost-effective healthcare system? What can we learn from all this and put together to design a system that would actually work, which has actually been my main interest for a couple of decades now. Okay, standardize the payment system. You want a universal system covering everyone. Single payer would be the most cost-effective way to do this. You could also do a pretty good job with an all-payer system, which is allowing multiple funding streams, but requiring them all to offer a single care delivery system. In other words, everyone has the same benefits, the same provider network of all qualified providers. Everyone is paid the same regardless of where the funding came from for an individual patient. And this allows health plans to exist, but it strips them of the competitive insurance business model. And this is exactly what they do in many other countries. France, Germany, the Netherlands, Switzerland, Israel, Japan, all have multiple funding streams, but they all have to offer the same care delivery system. And you can achieve 90% of the cost advantages of single payer with an all payer system. So either of those would be okay, but you have to standardize the payment system and the delivery system. When people talk about heavily regulated insurance and other companies, this is what they mean. They're required to offer the same thing.
Good question, Dr. Kemble.
Yes.
And in the all-payer model, I just want to make sure I have this correct in my head. All-payer model is essentially capitation. You have a marketplace of insurers, but you say, we're going to pay the same amount for everybody. Is that the nuts and bolts, or am I wrong?
I think largely all-payer systems do not use capitation. They may, I'm really not sure about that, because you could conceivably do it either way. The thing with capitation is that if you're talking about capitating an entire system, with a global budget for healthcare, that does happen in many places. And what they have to do is say, okay, if costs overrun, we're going to reduce the fees or the payment for things to compensate for the cost overrun. Or if you're going to capitate health plans, say you've got to cover all your health care within this budget, and if it costs too much, you're going to lose money. You can do it either way, but the bigger the plan, the more the population covers, the easier it is to handle the insurance risk. Whereas the more you break it down into smaller plans, the harder it is for them to manage risk, because they're not big enough to handle a high-cost case or two the way the entire system might be. So if they are capitated, it breaks down if there's too many of them. If they're not capitated, then government would have to have some way of making up the losses at the end of the year, or adjusting their budget on a regular basis to make sure they're not actually being damaged.
Okay, so then I guess I don't understand then with all payer how the payment works.
If you use the existing health plans, they would be collecting premiums per member, which is basically a form of capitation at the insurance level. And they would then, what you would need to do to make an all-payer system work well is they would have to pay doctors the same, as I said. So they would have to budget or negotiate their capitation rate to allow for that. Ideally, you would want to pay hospitals with operating budgets instead of on a fee-for-service basis, where everything has to be attributed to an individual patient, and they're charging $10 for a Band-Aid and things like that. If you pay hospitals a global operating budget, they have to pay for supplies, they have to pay for the cost of their staffing, their nurses, their medical assistants, their physical therapists, their doctors that are hospital-based. But they wouldn't have to attribute each thing to an individual patient. They could just pay for their operations. If you had an all-payer system, you could require all payers to pool hospital funds and then pay hospitals in that way, and achieve the same kind of savings you can get from single payer. Or you could pay hospitals with a standardized form of fee-for-service that would be somewhat simpler than what they do now, and they wouldn't have hospital charge masters playing games with the charges. So you would be able to save some money, but not as much as with global budgeting. So if you pay hospitals the global budgets from either from a single payer or from pooled funds for all payers, they would not be allowed to carry profits from one year to the next. So if you had any surplus from your operating budget, it would have to be applied to the next year's operating budget. And the way hospitals fund capital improvements now is by achieving surpluses from their operating budget, and they set that aside and build it up, and then they can have money to build a new wing or new MRI unit or whatever. So with a single payer system or a regulated all payer system, you would separate out hospital funding and have most of that allocated for hospital operating budgets. And each hospital would get their own budget. And then you have some money set aside for capital improvements that would be allocated by the single payer based on community need. In other words, there'd be some public planning. If you decide you need a rural hospital and you want to make sure it survives, instead of paying it with fee for service when there's too many unemployed people or people with low paying insurance plans there, you pay them with an operating budget and make sure they stay afloat because the community needs that hospital, not because it's profitable. So you have separate funding for capital improvements. This effectively covers the entirety of a hospital's budget. They have money for operations, they have money for capital improvements if it's needed by the community, and there's nothing left over to pay for executives of hospital chains, shareholders, profit, et cetera. In other words, it cuts off the funding streams for all those things, and you're only funding what's necessary to run the hospital. So you cannot have value-based payment, HMOs, accountable care organizations, integrated delivery systems, pay for performance, or risk adjustment, because all those arrangements include funding for hospitals. And if you've already fully funded your hospitals, it makes no sense to additionally fund one of these risk-bearing ventures for hospital services that are already funded. So you have to choose, are you going to use value-based payment, or are you going to use budgeting of hospitals? And budgeting of hospitals can reduce hospital administrative costs by half, because that's what's been shown in the countries that do that, including Canada and Scotland. They spend half of what our hospitals do on administrative overhead. And if you're just looking at billing and insurance related costs, it's more like 90%. Whereas value-based payment has never been shown to save money. So it seems to me obvious we should try to move toward budgeting, not value-based payment. This eliminates funding streams for hospital chains and profit. It eliminates billing and collections, which is about 10 to 15% of hospital budgets. It disconnects payment from the details of documentation because the hospital's budget is already set. And now you can document based on clinical care needs and quality improvement, not gaming documentation for payment. And it reduces hospital costs by 15% or more, enabling a 15% reduction in payment to hospitals without hurting them. What about doctors? Those doctors who are hospital-based would be paid with salaries from the hospital's global budget. Independent physicians, you can't pay them with salaries because they have no employer other than themselves. So you pay them with a standardized form of fee for service. So all payers pay them the same rates. There can be no ACOs, HMOs, IDSs, pay performance or risk adjustment in a cost-effective system, and no micromanagement of physicians by health plans. Prior authorizations need to be minimized and standardized, keep administrative costs low. And if you were to modify the way we do fee for service to a system based on the time associated with each procedure, so that whether you're doing a surgical procedure or talking a patient out of surgery, you get paid the same per hour no matter what you're doing. And that would be administratively much simpler and could reduce the cost of the system even more. With a well-designed single payer system, you could reduce physician practice costs by 10 or 15% and lower fees accordingly without hurting doctors. Now, for those integrated systems like Kaiser, The single payer proposals would allow a modified version of Kaiser so that a medical group that included outpatient doctors who are not hospital-based could agree to contract with the hospital and get paid with salaries from the hospital's global budget. And the global budget would be expanded to accommodate covering all the physicians affiliated with that doctor as well. So you would have the same doctor-hospital arrangement that Kaiser has now, but it would be paid with a global budget by the single payer and not from premiums. And this means that it would become an open system, that it wasn't closed like Kaiser is now. Anyone could see a Kaiser doctor, and Kaiser doctors could see any doctor outside of Kaiser if they wanted to. So it would open it up, and it would also eliminate Kaiser's insurance functions. They would no longer need to hire managers to deal with rate setting and underwriting and things like that that are insurance functions. And it would eliminate the funding stream that enables hospital chains. So Kaiser would be broken up into a whole bunch of individual hospitals with their physician groups, and there would be no corporate management of multiple hospitals. So those things would keep Kaiser as a pure care delivery system and strip it of its insurance functions. Okay, the fee-for-time proposal is to try to make fee-for-service as incentive neutral as possible. And if you pay doctors for their time and expertise instead of by the procedure or by documentation, then doctors are free to use their clinical judgment to do what's best for the patient. And that's the way doctors are trained. That's the traditional medical ethics. And if we rely on that and support it and encourage it, you don't need to micromanage doctors. You don't need to manipulate them with financial incentives. You do need to keep standardized fees reasonable. And the way to do this is collective bargaining. You require all physicians to join a professional organization which is empowered to negotiate fees on their behalf. What I would base this on if I were designing a system would be on training required for a specialty. So if you're in a specialty requiring more training, you do get paid more, but your hourly rate is standardized. So it doesn't matter what you're doing with your time, you're going to be paid the same rate per hour. And I would include documentation time and care coordination time in the hourly rate so that you're not being paid only for face-to-face time and everything else is on your own time the way it is now. So that doctors who work harder get paid more, but you're actually paid for what you do that uses your medical license. It would disconnect payment from the details of documentation and return documentation to patient care needs and quality improvement, and would eliminate the need for billers, coders, and scribes and people who are helping you generate huge long notes that maximize your reimbursement. It would be much simpler and cheaper to administer than either fee-for-service based on the resource-based relative value scale and E&M coding that we use now, or value-based payment, which is complicated by pay for performance and risk adjustment and detailed documentation and data reporting requirements. So it would be much simpler and cheaper to administer than either of those. Billing would be vastly simplified. You list all the procedures you did during the day. Each one is associated with a time that's the basis for payment. You send it in and you get paid a week later. That's it. You could do it in 10 minutes at the end of the day. Either the doctor or their office manager could do that. You wouldn't need to hire a biller. With fee for time, there's no disincentive to treat complex or difficult patients. If you need to schedule more time with the patient, you can schedule it and you'll get paid for it. And you don't get punished by taking on a complex patient the way you do with our current system or with value-based payment. There would be no built-in incentive to do unnecessary care because you're not paid more for doing unnecessary care. You're only paid for your time. Minimizes the need for utilization management and minimizes opportunities for fraud and abuse. Canada has far less problems with medical fraud and abuse than the US does because their payment system is simple and straightforward and doctors do what's best for their patient there. It would reduce the need for office staffing and overhead. This means that if you want to go into independent practice, it would become cost effective again. And there are studies showing that small independent practices actually do better at keeping their patients out of the hospital than large multi-specialty group practices do, because the doctors tend to know their patients better. If you are paid by time with standardized rates and you wanted to set up a practice in a rural or underserved area, you would actually do better than setting up your practice in a wealthy area, because you'd be paying lower rent. And your fees would be the same wherever you set up your practice, but your overhead would be lower in underserved areas. So there would be an incentive to practice in underserved areas. You wouldn't absolutely need computerization if you disconnected payment from documentation. Even though if you have it, it could be useful for those functions that are not involved with payment. All healthcare professionals should be required to join a professional organization as a condition of licensure, both to allow collective negotiation of standardized fees and to enable effective peer review and enforcement of professional ethics. Because if you had to join a professional association and you were found by peer review to be doing something unethical and you were evicted from the organization, you would be evicted from practice. Right now, only 17% of doctors are members of the AMA. So if the AMA decides you're doing something unethical and kicks you out, you can still practice. You can, especially if you move to another state, although the National Practitioner Data Bank is supposed to deter that. Physician organizations could use peer review to deter fraud and abuse. They could promote intrinsic motivation to do the right thing for their patient and professional ethics. They could sponsor continuing education. They could facilitate communication and referrals. And all of these would be covered by your professional dues at no cost to the single payer system. Right now, we're paying health insurance companies to do many of these things. All of those should be handled by the professional organization at no cost to the system. There are other things that would be necessary to optimize the healthcare system. These include community-based specialized services. Examples would be care of complex medical patients in the community, such as programs for seriously mentally ill, psychosocial rehab for schizophrenics, substance abuse services, collaborative care is psychiatric support for primary care through indirect consultation, where you have a psychiatrist paired with a social worker consulting to primary care practices. The social worker gets a history, talks to the primary care doctor and the patient, presents to the psychiatrist, who then gives specific advice to the primary care doctor on how to manage the patient, what medicines to use, what non-medical strategies might be helpful, things like that. And you could do the same thing for many other specialist consultations that don't involve immediate procedures. This has been shown to be cost effective. It is very helpful to primary care. And all these things need to be added to a comprehensive healthcare system in addition to fee-for-service payment for doctors and hospitals. These kind of community-based services almost always involve multidisciplinary teams, and they should be funded with global budgeting just the way hospitals are from a single payer, with professionals paid with salaries. And they should be made available to all patients and physicians in the community based on patient need and not based on insurance status or tied to a particular funding source. Care coordination would be best accomplished by eliminating the barriers imposed by competing plans, no narrow networks, arbitrary formulary restrictions, inappropriate prior authorizations, pay for performance, loss of time and attention to patients due to administrative tasks, etc. Coordination of care should be at the front line by caregivers who know the patients best. And if the frontline caregivers, especially primary care, have the backup of those community-based programs for special needs, they would not need to establish all those services within their practices. Quality improvement does require some funding, but a project should be sponsored by professional societies, and they should be developed at a local level by those involved in the care of the patients based on some demonstrated need or unreasonable variation in cost of care. Have the metrics developed by the participants in the project and modifiable by them and not controlled by central administration with a standardized pay-for-performance system. These could be funded with grants from a single payer at nominal cost. This is basically the Intermountain model for quality improvement, and it's really incompatible with centralized pay for performance because the projects have to be locally developed and they have to be locally modifiable. Drugs and durable medical equipment should have negotiated prices with a standardized formulary so everyone knows what's on and off the formulary. Prices would be negotiated regularly with a single payer, eliminate all the middlemen, the pharmacy benefits managers, and standardize and minimize prior authorizations. Cost control, if we did all these things, you would have global budgeting for hospitals and community-based specialized services. So that would make their budgets set and predictable. They're budgeted. You'd have public planning for allocation of capital expenditures for hospitals, nursing homes, et cetera, based on community need. You'd have physician fees negotiated with professional associations and reduced in proportion to administrative savings. Instead of neutral pay, minimizes fraud and abuse and unnecessary care. And you should manage manpower to keep it in proportion to community needs. In other words, a single payer should manage, that should determine how many training slots we need for each specialty, how many new physicians we need to be training each year. So those should be centrally planned rather than making ophthalmology very lucrative and primary care not cost effective and getting very skewed physician workforces based on the market. Those things should be managed. We should make sure that everyone gets paid in proportion to their training and expertise and that the fees stay reasonable because of collective negotiations and have some central planning of supply. Same thing for nurses, physical therapists, social workers. If you make sure that the numbers that are trained are in proportion to community needs, you don't need to worry about a whole lot of people trying to deliver unnecessary care because it's the only way they can stay afloat financially because there's way too many of them. And you should manage insurance risk with risk pooling, with a single risk pool and not shifting risk onto providers.
Dr. Kemble?
Yep.
So how do you deal with, given just the sort of political climate of America, how do you deal with, specialists that have a good deal of power because they have so much money, influencing the political process? Because, right now I'm thinking, of course, of orthopedists because they're the ones that are always thought of in this model. They're making a lot of money. How do you maybe there is a model that could be advocated for that's super cost effective and that would be enough. But my assumption is it's very difficult to advocate that because of the power held by those specialist kind of organizations. How do you create a model where they still retain some element of their ability to do more and make more, kind of the fee-for-service model? And maybe the answer is you can't, but how do you kind of like throw a carrot to those groups so that they're not going to like die on the sword to try to stop this?
Well, you're raising a very good point. And my thoughts about that are, if you start by requiring everyone to join a professional association, and I'm going to use AMA as an example, not because I think AMA the way it is has the desired characteristics, but because it's multi-specialty. So if you have something like the AMA that's saying, okay, you're going to be responsible for negotiating physician fees, and everyone's fees are going to be standardized, and you can pay specialties that require more training more. That's fine, you should, but everyone's going to be paid in a standardized way. If you force all doctors into the same organization, they have to deal with each other. And to me, the attractiveness of the fee for time idea is that if you base the hourly rate on training rather than each specialty saying, well, our services have so much value and we think that because this is really complicated and difficult to do and it's a new service that you should pay extra for it. Instead of doing that, you say, okay, how much time does it take? And you pay based on the time, because every procedure has a typical time that it takes. And if you have a complication or an unusually complex case, then you can bill for the actual minutes. But otherwise, you get paid a standardized fee based on the usual time required for that procedure. And that eliminates a lot of the gaming. And because the hourly rate is adjusted for training, that gives you a basis for determining a differential between the orthopedic surgeon and the primary care doctor that is not based on playing games in a smoke-filled room in the back. It's out in the open. It's pretty straightforward. How many years does it take to become an orthopedic surgeon? Or maybe a couple extra years if you're going to be a hand surgeon or specialize in some areas. So you get paid for the training required for your specialty. That influences your hourly rate, but there's no gaming in the background going on. It's just based on the training. And to me, that would be the way to force doctors into working with each other and give them a way to think about it that would reduce conflict. I'm not saying that would solve the problem completely, but it's a pathway toward a solution. Does that make sense?
Yeah, and what I'm comparing that to is, and my knowledge isn't 100% fresh, but I'm thinking about Britain and their kind of gatekeeper model, where you got to go through primary care to get to specialist, and the specialists are, I think, 100% salary, and hired by the hospital, so they don't care. You know, they're just accountable to their professional organizations for the quality of the procedures they perform, and that's how they do cost control, which is very effective, as we know. But I'm like, just because we have the system we do, it's tricky, and I mean, by time is a more ethical model, certainly, but I'm thinking of how, they're going to be like, well, we've got to buy this equipment. The equipment's expensive, so then there's one loophole there where they're going to say,
well,
they're going to.
You would have to base the hourly rate on training, on time, and also on required practice overhead. So if there's equipment that you have to be an ophthalmologist or an orthopedic surgeon, like you got to have an X-ray unit in your office, and you got to have all this specialized eye examination equipment, you could add that in. Practice overhead is a reasonable factor in determining the fees. You don't want a system where you have an incentive to get a whole bunch of marginally necessary equipment so that you can run up the bills. And so there need to be some negotiations on that. But I do think that practice overhead should be included. I do think you could require all specialists to be employed by hospitals. As with something like Kaiser, where you have a medical group affiliated with the hospital and paid through the hospital's budget, you could do the same thing with specialists, but it would eliminate independent practice for specialists. And there might be resistance to that too. The fee-for-time system would be, if you want to retain independent practice and you can't capitate specialists, how could you pay them in a way that would be reasonable and balanced with the need to have adequately paid primary care as well? And this is my thought on how you could do that. But yeah, there are other ways of doing it too. If you put them all on salary and make them be affiliated with a hospital. Salary is actually a time-based system also. You're being paid for your time and expertise with salary also. So it's really the same fundamental basis as with fee for time. This is my last slide.
So I have a question. I'm currently working on a project with Louisiana Medicaid, and something we're dealing with that I'm looking into right now is there is a program, it's specifically supervised exercise therapy, that's being underutilized by Medicaid patients. and hospitals are kind of pushing patients towards the more intensive revascularization for as a treatment. So my question, obviously, I don't expect you to kind of solve my problems straight out, but the question is, if you wanted to change clinical practice, you know, through reimbursement, you know, how would you approach that, do you think?
I would basically approach it by trying to control manpower to make sure that the number of providers in a given specialty, or you know, both medical specialties and also non-MD specialties like physical therapy and things like that, make sure there are enough in proportion to community need with some central planning, and then fund the ancillary services with global budgets to do what they do, and then make them available. So that that would be how I would organize that in a way that I think would be cost effective. Most, I think most of those kind of ancillary services work best with some kind of interdisciplinary care model, so that you have, let's say you have physical therapists and they have, I don't know, that if you have a physical therapist who runs into a problem that's not usual and they need physician backup, there ought to be clear pathways for them to get that. There should be a doctor available to the group that they could refer to for something that was unexpected or complex, that didn't fit what they're used to dealing with. So you would want to have clear pathways to have different levels of expertise working together with each other. And that's why I think they should be generally interdisciplinary and generally funded with global budgets, with professionals paid with salaries, and then they just take care of the need. And you keep the need in proportion, I mean, you keep the manpower in proportion to community need with some central planning. That's how I would do it.
So kind of my issue is that like a lot of that kind of has to be done on the hospital end. You know, they have to support these programs and kind of push for it. And if, you know, we increase Medicaid reimbursement, do you think that would have the downstream effect of, you know, pushing people to have, you know, increase the efficiency of those programs? Or do you think it would kind of just fall on deaf ears?
Well, I guess, to get closer to the situation you're actively dealing with, you have services that are under the auspices of a hospital, which is largely paid with fee for service, and which makes more money by delivering more services, and also makes more money by delivering better paid services and not underpaid services. So there's all kind of skewed incentives in that system. So in an ideal system, they would all be paid with a global budget based on community need, and all those games would go away. But you're having to deal with the games in reality when you're trying to tweak the existing system. I do think that it would be desirable if does Louisiana have Medicaid managed care or not?
We do have managed care.
Yeah. If you required the managed care companies to pool hospital funding and have the state allocate those fundings with global budgets for operations and separate budgets for capital expenditures, the way single payer proposals would recommend, and then have the managed care plans only cover outpatient care, you could eliminate a lot of those problems. But it requires a radical rethinking on the part of the people running the managed care program and the Medicaid program to get there.
Ashwin and Dr. Kemble, can you explain that to me a little bit? You lost me at some point, but it was interesting until I was like, what?
Okay, the most cost-effective way to pay hospitals is with budgets. But that means you have to have a pool of funds to pay the hospitals with that's drawn from all available funding sources. If it's a single payer, it's straightforward. If you have multiple payers, you have to say, each one has to contribute to this public fund in proportion to the hospital needs of their population. And you could base that on past experience, on a rough idea of how sick their patient population is, things like that. You calculate what their share of the hospital fund should be, and they have to send that as a lump sum to a public fund to support hospitals. That public fund then budgets hospitals and keeps part of the money separate for capital expenditures and allocates that according to community need. That removes hospitals from what's being managed by the plan. So they're left with everything that's not hospital care. They have long-term care, they have outpatient care. If you were to put nursing homes on the same basis, it would take that out of managed care too, and then they'd be left with care homes and home health care and things like that. So it greatly reduce what the managed care companies are managing because hospitals' budgets are already fully funded by the system.
Which means hospitals are no longer incentivized to do anything other than what actually works.
Right. Yeah, they have to take care of what comes in their doors. That's it. And allocate their funding accordingly. And they don't need to worry about who's being charged for which service. They don't need to worry about how they document other than what is necessary for patient care and quality improvement.
And Ashwin, that's what you're dealing with in your study, trying to figure out the solution?
The issue is more that's the way there's a problem with the way incentives work for being paid. And Dr. Kemble, Dr. Kemble, you can.
Well, yeah, I think that the problems with fee-for-service driving unnecessary care are largely hospital problems. There is some problem with procedural specialties as well, and there is no problem with primary care. So having a value-based payment system that's capitating primary care is aimed at all the wrong things. It's missing the problem completely, because there is no problem with excessive care due to fee-for-service in primary care. The biggest thing is hospitals. So if you take hospitals off of fee-for-service and put them on budgeting, you can solve a large portion of the problem. Many of the procedural specialties that overdo procedures are actually doctors that are employed by hospitals who are pushing them to do more because the hospital gets the revenue and they use it to pay the doctor. So if you were to put hospitals on budgets, you could eliminate probably 95% of the problem of overuse of care due to fee-for-service. That's where the money is.
And hospitals are doing that because their budgets are so tight already.
Yes, they're tight, but they also have very high administrative costs.
Right.
So my idea is let's eliminate the administrative waste, and that takes the pressure off the hospitals, and also it eliminates the incentives to play games.
And their administrative costs, once again, are high because they have to deal with insurance companies.
Right.
A couple other things, but that's probably the biggest.
Yes. I think the best Medicaid program now is probably Connecticut, and it might be worth looking in more depth at what they're doing. I'm sure they're not paying hospitals with budgets. They're paying them with some form of fee for service, but I know they did improve primary care fees substantially, and they implemented community-based services to support primary care, and they achieved much higher physician participation and reduced hospital usage. I know they did all those things with just what they're doing now. Even if it's not my ideal system, it's a big step in the right direction.
If you could sum up briefly, why do doctors hate Medicaid?
I mean, I went through this personally because I started practicing in Hawaii in 1985 as an independent psychiatrist. And at that time, Medicaid was a fee-for-service program. And it paid about 2/3 of commercial rates. And yet almost every doctor in Hawaii took Medicaid. And they would sometimes, or often, maybe limit Medicaid to 30–35% of their practice. So they wouldn't take unlimited Medicaid, but they all took some. And if you had a patient with Medicaid and they needed help from some other specialty, you could call a doctor and twist their arm a little bit and they would take the patient. And it wasn't hard to get Medicaid patients into whatever care that they needed. When we converted to managed care, what that did is they kept the fees at about 2/3 of commercial rates, but they added a whole bunch of prior authorizations and a whole bunch of obstacles to getting paid and a whole bunch of obstacles to doing what the patient needed. You couldn't just write a prescription and expect it to be filled. You know, a third of the time it needed a prior authorization. You had to jump through hoops. And what happened is that doctors stopped taking Medicaid. That's what happened. And it wasn't because of the fees, they stayed the same, it was because of the hassles. They just were not willing to deal with all those obstructions to care. Now, the problem is that once a doctor quits taking Medicaid, if you say, okay, we're gonna stop all the managed care, we're gonna pay you 2/3 of commercial rates, come back in, they won't. Once they're out, you need to sweeten the pot to get them back in. So what Connecticut and North Carolina did is they raised primary care rates to Medicare rates, so that at least you're being paid something more toward the average of all your patients in your practice, and you're not going to get hurt by taking Medicaid financially. And if you're not being micromanaged by insurance companies and you have the backup of those community programs for special needs patients, doctors were willing to jump back into Medicaid.
That's part of my concern, which is that, you know, one possible solution is requiring prior documentation of failed exercise therapy before reimbursement for revascularization. But, you know, I risk excluding some part of the population, you know, because vascular surgeons could then say, I don't want to deal with it. You know, I don't want to deal with that extra hassle. So is that justification enough to move away from trying to add that extra administrative burden? Or, you know?
I think it's a little different in that scenario because the administrative burden falls on the primary care doctor, not on the vascular surgeon. By the time the patient gets to the vascular surgeon, they've already got the prior authorization, so they don't have the hassle.
Okay.
And so I think you can make that work.
Thank you.
Going back to the hospital question, does basically in any non-urban setting, do you basically need hospitals to be publicly owned to make them not even cost effective but continue to exist? I mean, is there any other solution?
I don't think so. I think that's it. They need to be publicly funded and have a guaranteed budget and not be dependent on collecting fee for service. You know, when Medicaid was implemented, this is another example from my own experience. I started my psychiatric training at Cambridge Hospital at a time when public sector and mental health care was all funded by the states. And they paid for a state hospital and they paid for community mental health clinics. And they used, during deinstitutionalization, they used the money that used to go to all these state hospital beds to fund community-based psychiatry programs, like the one I was training in. And when Medicaid came in, which is around the same time, they said, wait, we need to tap into Medicaid because it's at least 50% federally funded and we can pull in federal dollars. It's not going to all be on the state. So they started rearranging things to take advantage of Medicaid. And that meant you're locked into fee-for-service payment because that's the way Medicaid was originally designed. And that eliminated the flexibility to fund, you know, community care workers and community consultations and case managers and things like that that didn't fit neatly under the fee-for-service payment system. So it really damaged the ability of the program to meet community needs because they were now locked into fee-for-service in order to capture the Medicaid dollars. So this is why I say you need a significant chunk of funding in a single payer system to fund those kind of community resources that are interdisciplinary and don't work well under fee-for-service, to fund those as block grant, global budgeted programs with professionals paid on salary. That's an essential component of an effective single payer system. And it's by far the most cost-effective way to do it, by far. Like with psychiatric collaborative care, which I'm involved with, CMS has a funding mechanism which involves, since the psychiatrist doesn't see the patient directly, the primary care is the one seeing the patient and prescribing the medicines. The psychiatrist and the social worker keep track of their time for a patient and bundle it as an episode of care on a monthly basis. Turn that over to the PCP, who can then bill Medicare on a fee-for-service basis. They have to charge the patient a copay, and they then have to reimburse the psychiatrist and social worker for their time out of what they were paid. That funding mechanism is very clunky. And in Hawaii, we haven't been able to get any payer to actually make it work. So the way we're doing collaborative care is that one of the major hospitals here is funding it as like a block grant, so that it's got a set funding. The professionals are paid with salaries, and they just deliver the services to primary care based on patient need. And we don't charge the patient a copay, and we don't charge the primary care doctor anything. We don't impose any administrative burden on them. It's just funded by a block grant that pays my salary and the salary of the social worker. One collaborative care module is 2 hours a week of a psychiatrist time and a full-time care manager and some administrative and IT support. That costs $160,000 per year and can cover 80–90% of psychiatric care needs for about 15 primary care practices. That's extremely cost effective. Also, I've been in forums of psychiatrists all over the country that are trying to make the fee-for-service mechanism work, and they're all having problems, and they're all getting together saying, what are you doing? How is it working for you? How could we make this work better? Does anybody have any idea how to make this work? And we're just sailing along and it works great. One other effect is that when you're using the fee-for-service mechanism, the patient has a copay for a doctor that they never see, and a lot of them balk at that. So the patients that are referred to collaborative care all over the country engage with care about 60% of the time. We're running 80% engagement because there's no hassle to the patient or for the primary care practice to participate in the model. So the way you pay has a big effect on the effectiveness of the services too. And funding it with a global budget based on community need is much more cost effective.
And would you say that psychiatry is particularly, I'm not sure the phrase, well suited or likes this payment model because patients are poor on average if they're seeking psychiatry? They're often on Medicaid. Is it those incentives? What is it?
I think that psychiatry is sort of obvious because psychiatrists don't do procedures, or at least not much, other than electric shock therapy and RTMS and a few things like that, but they generally don't do procedures. And what's really needed is their expertise, and you can do that through primary care. So it's sort of an obvious place to start. But in fact, the same thing works equally well for, like, if you have a diabetologist consulting to primary care on complex diabetes patients, if you have rheumatology consults, if you have infectious disease consults, a lot of other specialties would work just as well using this type of model. And as long as they are being paid reasonably and it's hassle-free for them, they love it. I mean, it's very simple to administer if you do it that way.
And final question, I'm sure we're probably over at this point, but the is the payment coming just directly to the clinic? It's just covering everybody, primary care, psychiatry, social work. Is it just sort of covering everybody's salary and costs as a unit? And you just have
for the primary care doctor, the primary care doctors we're supporting are either employed by the hospital or one of their satellite clinics, or they're independent practices that have a contractual relationship through a independent physician organization with the hospital. So they have to have some kind of contractual relationship or be employees. When we consult to an independent primary care practice, we say, okay, you have a patient that has psychiatric needs, you put in a request for a consult, we respond, we give you advice, we follow through, and it costs the practice nothing. So our salaries, the psychiatrist and social worker, are being paid by the hospital as a grant to cover the program. The primary care practice doesn't have to worry about what the patient's insurance is. So if they are seeing, Medicare patients, Medicaid patients, and they need our services, it doesn't go through the insurance. We just cover it. So it doesn't, and we make it available to them regardless of what the patient's insurance is, because we're not billing the insurance. But you need a funding stream outside of fee-for-service to make that work. And the way we got it in our case is that the dominant insurer here, which is a Blue Cross Blue Shield plan, HMSA, wants to support doctors and hospitals forming independent practice associations and accountable care organizations that can accept insurance risks. So they're putting funding into it for those purposes. And we use some of that money to pay for things like collaborative care, which is outside the fee-for-service system. So you do need a funding stream outside fee-for-service, but if you do establish that, it's still going to cost you much less than it would be to run it through fee-for-service.
Great, thank you.
We're on until the top of the hour, which is about 18 minutes away. If you like, if there are any more questions, we can answer them, or we can take a break. And we need to decide, do you want to go ahead after a break and do the psychiatry part of this, which in many ways, especially care of the seriously mentally ill, is intimately tied up with Medicaid. So one leads into the other. So we could either do that today, or if you guys are exhausted, we could reschedule it for another day, and we need to decide that. What do you think?
We would be able to do it another day?
Yeah.
For sure.
Yeah.
Would it make more sense though if we did it today, given the information we were shown?
I think to some degree, having the Medicaid information fresh in your mind would facilitate the psychiatry, but I think that's a small consideration, and it's really, we could do it either way. It would work either way. It's not a big deal.
Personally, another day may work better. I'm feeling a little burnt out right now.
Okay.
Yeah, I'm completely comfortable with that. I do actually, Dr. Kemble, I do have, because I'm interested in going to psychiatry, I do have some questions for you, but I don't think everyone needs to be on the call, is all I'm saying. So, and I can also wait to ask them till our subsequent.
They're specifically about psychiatric care?
About being a about practice.
Yeah.
I'm just curious about your experience.
Yeah, sure. Well, that is definitely part of what the next presentation will cover.
Do we know when we could do it potentially if we did put it a different day? Because obviously we want to make sure that we're still able to do it at some point.
I have to talk to Betty Keller and Marvin Malik, but I'm only working 12 hours a week and I have a fair amount of flexible time, so it shouldn't be too hard. Generally Tuesdays and Wednesdays and Friday mornings work best for me because I'm 6 hours behind you guys, or ahead of you guys rather.
Well, thank you so much for this talk. This was
You're
very
welcome.
informative.
It's been really great. Thank you, Dr. Kemble.
Yeah, thank you a lot, Dr.
Thank you a lot.